Hello, everyone. We're going to give it a moment for folks to start coming in the virtual room. Thank you so much for joining us today. While we're waiting to get started, you can feel free to put any information in the chat box if you want to say hello and tell us where you are dialing in from. I know we're also going to have plenty of folks be watching the recording afterwards, so we will get started in just a moment because we have a lot of fantastic content today. And yes, Juliette's putting a note in the chat box that if you'd like to send a message to everyone, make sure you select that from the dropdown. Or if you need to send a message just to the host and panelists, you're welcome to do that. So let's give it another minute to let folks join. Hi, Erin. We do want to give as much time as we can to our fantastic presenters today, Dr. Lynn Hollerman and Dr. Fred Blow. This webinar is from the National Center for Equitable Care for Elders. My name is Arielle Mather, and I'm the program manager for our center. And we're so excited to be presenting content today on the role of family caregivers in identifying and addressing substance use disorders in older adults. So like I mentioned, we're going to have many folks be watching this recording as well. So we'll go ahead and get started. If you are not familiar with our center, there's a lot of links here on the slides. You will receive those slides promptly after this session wraps. We'd encourage you to connect with us. You can check out other training and technical assistance opportunities that will be coming up in the new year. And we'd love to hear more about your needs and how we can provide you with those resources. Another fantastic resource is the Health Center Resource Clearinghouse. I've highlighted on this slide just briefly the COVID-19 priority topic page, which has up-to-date information for health centers specifically, but other community organizations can really benefit from it as well, especially as so much new information is coming out around vaccination efforts, particularly now as we're spanning across ages and being able to receive initial vaccines and boosters. We're all pros at Zoom already, but just a couple of reminders that all lines are automatically muted to prevent echo and background noise, but we would love to hear from you in the chat box or using the Q&A feature. You will receive the webinar recording and the slides after this session wraps today. And when you close out of Zoom, you will receive a link to the evaluation for this session. We'd love to hear your feedback. So please take a moment to fill that out. And you saw the learning objectives when you signed up for this webinar, but we're really excited for both of our presenters to really dive into content related both to COVID-19 and its impact on SUD in older adults, and then talking about screening strategies, as well as how we can really empower caregivers and family members of older adults to access the resources that they need in this area. So without further ado, I'm going to introduce our first panelist for today, Dr. Lynn Hollerman, who is a subject matter expert on our team. She is a board-certified palliative care physician. She's been a leader in palliative care program development for nearly 2 decades. Dr. Hollerman served as the Director of Palliative Care Services at Stony Brook University Medical Center from 2007 to 2019. And prior to starting and building that program at Stony Brook Hospital, she initiated and developed the palliative care program for the VA Maryland healthcare system. From 2017 to 2018, Dr. Hollerman served as a residential congressional health fellow on the Senate Committee on Finance for Senator Ron Wyden. She currently works as a palliative care educational consultant and writer. And actually, Dr. Hollerman is the author of a recent New York Times guest essay on the importance of caregiving for older chronically ill adults. And with that, I will turn it over to Dr. Hollerman.
Hello. So if you, we're just going to dive right in. So if you want to just go to the next slide, Arielle? Okay, so I'd like to say also just thank you everybody for getting on a webinar in the middle of your busy day. So we all really appreciate that. I'm hoping it'll be worth your while to stick it out for the hour. We have a lot of good information and tools for you. You can stay on that slide. So anyway, I'm going to pause on this just for a minute because I just want to clarify who exactly we're talking about when we say what is substance use disorder for this talk, and especially how it applies to older adults with a serious illness such as heart failure, dementia, or an incurable cancer, or in a patient who has a chronic illness, chronic serious illness like diabetes. So we're really focusing in on that population. Not all of these patients need caregivers, but when they do, if for this talk, we're going to be really focusing in on unpaid family caregivers and how they can support a range of activities. It can be someone who lives with the patient, a wife or a husband or a daughter, or it can be someone who's stopping by a couple of times a week to help with homemaking activities. So there's a real range when we mean caregiver. The other thing is also older adults. That's a really big term also. So I just want to make sure that we're talking about someone who needs care, somewhere on the spectrum of that. So the take-home message really I want to say to you also is when we think about substance use disorder in this, I'll say the caregiver patient as one unit together, and the give and take between those two people, as I think Dr. Blow will go into also as well, is simply that when someone has a history of substance use disorder or is developing one, the interrelationships between caregivers and patients can get quite complicated. There can be lifelong history of substance use disorder that's impacting someone's ability to take care of someone older. So it actually can get very sensitive and very difficult to deal with this sort of dynamic between a caregiver and a patient. Particularly, it's possible the caregiver also is enabling the caregiver can have their own substance use disorder problem. So keep all that in mind as we go through this today. Next slide. So I'm just going to put up this definition. I think it's worth just spending a little bit of time reminding people what these sort of official diagnoses of substance use disorder. And they'll talk about a problematic pattern of substance use leading to clinically significant impairment or distress. I always say this, the more simple way of saying that is use despite harm. If you look at this list, though, I'm not clear that it's very easy to identify these things in someone who's maybe 80, who has substance use disorder. It can be tricky. But I think it's worth getting familiar with these issues and see how you can apply them to patients that are older. For instance, recurrent use in situations which is physically hazardous. For the older person, it might be that they're using a walker and then they're more at risk for fall because they're losing their balance. So you have to sort of look at this, but understand that when you're talking about someone with a serious illness, that you have to sort of think a little bit outside the box. I also want to really encourage people to really utilize an interdisciplinary approach to exploring this, meaning that if you're working with social work, case management, that everybody's on the same page with kind of teasing out what's going on with the patient-family dynamic, and that you don't just have one way of doing it, that one person is doing it. It's probably going to be less successful. New slide. So I love poll questions, so we have a poll for you. So just put down what you think are the most likely drugs to be misused in older adults. And when we talk about synthetic opioids, that can be something like fentanyl, which is a highly synthetic opioid, but more commonly something like oxycodone, Oxycontin kind of things are synthetic opioids, for instance. Hey, Tiff, do you want to show us the results for that, if we have any? Okay, what did people say? I like that people forget about benzodiazepines, so I like that people put that one. Alcohol is tied, it looks like, with opioids, tobacco. Okay, so let's talk about this a little bit. Okay, let's go to the next slide. I'm going to give you sort of an overview with all this. Now, this slide actually only represents alcohol, marijuana, and cocaine. It doesn't account for other types of misuse. But however, you can see that if you think about what older adults are using the most of, it's probably alcohol. And this is borne out in these statistics. I just wouldn't forget about marijuana, actually, because first of all, in many states, it's become legal. I think if you're talking about the boomer generation, there's a good chance that many people had exposures um, to marijuana earlier in their life and are more willing to try it, especially that it's now that it's legal. Cocaine does happen. When I worked at the VA for years, and the Korean and Vietnam veterans often had problems with heroin and cocaine kinds of things. So you shouldn't rule these things out in older adults. And I think what I really want people to take away from this talk is don't just assume because someone's older or 80 that they're not using. I think that's one of the things that comes up a lot. You just kind of miss it. That's why it's so important to think about it and ask about it. The other comment I wanted to make is also just try to be as evidence-based as possible if you're going to suggest that someone use marijuana. You might have some well-meaning grandchild who's showing up with a bag of weed, wants to make some brownies, whatever, and give grandpa, a taste, but there could be really serious unintended consequences for that for your patient. And I think patients really need to be educated about the risks of marijuana. There are some real uses for THC and CBD that have been shown, like for nausea, for chemotherapy, and so forth. But just try to follow the literature and don't find yourself just saying, sure, use some marijuana, no biggie. I would avoid that kind of thing in a professional setting. The other thing just to remember that it's really important to start warning patients about is that the fentanyl, there's a huge fentanyl problem with other things that people consider safer, so-called, like marijuana, are being laced with fentanyl, and people are dying left and right from getting something off the street and then the drugs, or from the internet, by the way. So you should just really be careful about that. And you have a lot of inadvertent deaths from fentanyl. That's in epic proportions right now. So it's another thing, even with your older patients, to make sure that they have educational literature about the dangers of using street drugs. Basically, it's become even worse than it was. Next slide. These are just some general, just to sort of give you an idea. This data is actually a little old, 2018, but the only point I wanted to make from this slide is that my personal opinion is that you can see as people get older, there's less drug poisoning, death by drug poisoning, but I suspect it's under-recognized in older adults, and I think those numbers are going to really start to change in the context of the pandemic. In the setting that I worked at for years, I would get calls, for patients with an agitated delirium, and then people would be looking for infections and withdrawal from other kinds of drugs, but they wouldn't really think of some alcohol. They wouldn't think of other things. I would have a family member say, hey, grandma's been taking Valium 10 a day since she's 35, and nobody thought about it. Nobody did a substance use disorder history in that patient. So it's just something to think about. Next slide. I'm going to say that it's just been an incredibly difficult time to be older during the pandemic. The pandemic is not over. We thought we were going to get a respite, and then now we're in this new kind of surge. I think the impacts and what I'll call compounding impacts on older people are becoming extreme and exaggerated in that group. Just as an aside, like my father-in-law, we were supposed to do an 80th on Saturday, but one of his kids now got exposed and can't come. And I think these kinds of ripple effects and unintended consequences are just huge. Also, older adults not being able to get regular care that they need. And then also turning to substances to try to find some comfort in an incredibly stressful kinds of situation. So I think responding to all this has become incredibly challenging as a care provider. Trying to screen for substance use disorder over Zoom, it can be, in this population, it can be very tough, and you have to have a lot of groundwork before you can have those kinds of sensitive conversations with people on a Zoom call. So, I think it's particularly tough right now. You can go to the next slide. So, if you were following the news, I think in November, I've been following this number for a couple of months, and they keep putting up these provisional number of overdose deaths. This is from November, but it's about 100,000 people, not specific to older adults, have had overdoses, in the last year or so. So it's just an extreme amount of people. A lot of this is due to fentanyl. So I just think to keep your antennas up about all this with your older patients is incredibly important. This data is unfortunately not drilling down to older adults, but just they're the ones you're going to see these patients. They're the ones who are going to end up in healthcare settings, these older adults. So it's a real opportunity to educate where you might not be seeing the younger patients who are overdosing. You might be seeing your older patients for other reasons. So just something to keep in mind. Okay, we have another polling question. This one's a quick one. I'm mainly just curious to see what people are going to say, whether they actually have a tool that they're using. Okay, Tiff, you want to just see what people say? Oh, people have, I think people need to put that screening tool in the chat if they love their screening tool, to share it with the rest of us. And what I found, you can go to the next slide also. What I found is that with a lot of screening tools, they're not very specific to older adults. So as I was saying earlier, with the definition of substance use disorder, you can use these screening tools, but they're not necessarily very helpful for your older adults. I put this up here mainly just as a resource for everybody. The website is at the bottom. And it's just a list of different kinds of screening tools. And if you don't already use one of these, just go into the site and peruse through these screening tools, see if there's anyone that seems to fit your patient population, or at least to educate yourself about the kind of questions. So when you're applying it to older adults, you'll have an idea of how these screening tools work. But in terms of validated screening tools for older adults, it's hard to find one that really fits completely. And if you have one, that's great. You should let us all know. Okay, next slide. Okay, this is just an example screening tool, and I'm going to spend just a little bit of time on this slide. This is actually from UpToDate. I don't love it, but I find it a little confusing because they say in the past 12 months, how many days, and that's kind of a big time frame to ask people 3 or more days. So I wonder if they meant 3 or more days per week or 1 to 2 days per week. So it doesn't totally make sense to me. The other things I want to point out here, like for instance, 4 or more alcoholic drinks, that would be a really lot of alcohol for your seriously ill or chronically ill older adult if they were up to 4 a day. And I don't have any alcohol in my house, but this is actually 5 ounces. This is the standard amount for a glass of wine. So that to me that's a hearty pour, at least, in my world. And I think it's worth understanding these amounts. Depending on the cultural background of the patient, their idea of how much alcohol is acceptable can be quite different. So you have to be sensitive to whatever cultural setting you're in, to understand and what the standard is. Also, for instance, in my social group, this is an IPA. Actually, it says comfort hops on it. So it's very enticing if you're isolated and alone. But this is actually 16 ounces. It's not even 12 ounces. So that's actually a lot. And the alcohol content on this is 8.5%. So this is a hefty, hearty drink. And I think, in my social circles, like 50 to 65 years old, these are very popular right now. So I think it's worth sort of understanding what people are drinking, and even doing things like having an educational table out in your clinic where you're actually demonstrating these amounts and having a quiz about their drinking and maybe giving them a Dunkin' Donuts card if they get them all right. Something to educate people on the sly that you're doing for group. I would highly recommend that you do that. Another problem with this screening, for instance, also like any prescription medicines, recreationally so-called, but when you're 80, the reason you may be overtaking a medicine could be potentially because you want to go to sleep and you're double dosing on a drug, or you're anxious. Like there's a lot of reasons to use prescription medications sort of as self-medications beyond what you should be using. And that it's not really captured in this screening tool, and it's just something to be mindful about. Next slide. I always say, in my world, in the palliative care world, when you're dealing with patients with chronic illness, is function, function, function. You can learn so much about somebody and what's going on with them if you pay attention to their function. And it's the same thing with substance use disorder. If you have a patient, these are the kinds of standard questions you should be asking anyway if you have a caregiver patient situation. But if any of them are coming up as red flags, for instance, if you're having someone with frequent falling or some situation like that, or they're avoiding people, or your uncle who used to come to all the family events, who had a history of alcoholism, they're suddenly not showing up anymore, you can't reach them on the phone, you should really these are the kinds of things you want to have your antennas up for, are these kinds of things, and to make sure that you're asking about alcohol, you're asking about prescription drugs, all those kinds of things. So I think this is actually a more useful way for older adults to really kind of keep track of what's going on. And if you have big changes, you should always say to yourself, could there be a substance use disorder behind the problem? It can get, it can also in older adults, like it can come out in very different ways. Like for instance, my mother, 92, dementia, she was never that interested in alcohol, but suddenly when you took her out to lunch, she always wanted a drink. And I couldn't stand having to be, the one to tell her not that she couldn't have a drink. So I think there's a lot of emotional content with trying to negotiate with our older, we don't want to insult them. You want to preserve their dignity. We don't want to infantilize our seniors. So it was very difficult for me to take away alcohol from my mother. However, she went out with some friends and we told them no drinks, but she, badgered them into ordering a drink for her. And she came home, she probably had half of the drink. And proceeded to fall off the toilet and break her wrist. So, even though you don't necessarily have someone that's actively using substances, into the levels that we think of having a substance use disorder, in older adults, even these small amounts can actually add up to a catastrophe. So you should just sort of think about that. In the case of my mother, we just really had to make sure there was absolutely no alcohol in the house, and we had to sort of be harder about it than I wanted to be. But this is something, if you talk about just speaking with families and patients about this, you can make a huge impact on these kinds of things. If someone has a major substance use disorder problem, you might be harder to do that. But just the conversations, you really can't have the alcohol in the house. You have to do all that. You can make a huge difference. Okay, if you go to the next slide. So, okay, I put this slide up for a very specific reason. This is basically saying where people got their pain relievers from, and I think it's mainly, we're talking about oxycodone, OxyContin kinds of things. But what I want you to notice is, a lot of people get pain relievers from a doctor, but the other place they'll get it is because it was taken from a relative or a friend, it says given by, bought from, or took from a friend or relative. So the angle that I want you guys to pay attention to really is simply that your older adult, one, can be victimized in the sense that they could be more vulnerable if they have drugs in the house that are not being lockboxed away. And you can actually get a dispensing lockbox now. I want to say that Medicare pays for it, but I'm not positive. That they need to be accounted for. And these are all things that are very critical. One, to keep your older adults safe from kinds of abuse related to stealing their medications. Or you can have a caregiver that's actually taking, the person's medicines also to sleep, or they may have their own problem. It can get very, very complicated. The other thing, I just wouldn't just make assumptions that the older adult is always the victim, and you should just sort of say, like, is this person like, is it grandma, the neighborhood dealer? I mean, you need to think about the spectrum. These are people. Because they're older, it doesn't mean that they're people like the rest of us. They're human beings. Or could they be selling drugs to pay for food? And all these things I have had in my 20 years, I have had all of these scenarios. So you just have to sort of keep these things in mind if you really want to serve the population. Okay, now I am actually going to stop, I think, with enough time. So if anyone wanted to ask a question right now, they can do that before we move on to Dr. Blow.
Sure, yeah. So as mentioned in the beginning, thank you so much, Dr. Hollerman. If there are questions or just
Comments?
any insights that folks want to share from their own personal experiences, feel free to utilize the chat box or the Q&A feature. Certainly our team will keep an eye on that throughout this second half of the session. And we can always circle back to both of our speakers at the end to get their insights on questions. So we will, I don't think we have any right now, but I think we'll give folks some time to think on that. Again, would love to hear folks' individual experiences as well. So thank you again, Dr. Hollerman. We'll circle back with you at the end of the session. I'm now going to introduce our second fantastic presenter, Dr. Fred Blow, who is a professor and director of the University of Michigan Addiction Center in the Department of Psychiatry. He's a career researcher and educator in the fields of alcohol and substance use screening, interventions, and treatments. The large body of his work has been directed to providing the research base and training scholars and clinicians alike. Dr. Blow currently has 2 National Institute on Alcohol Abuse and Alcoholism grants and has had continuous funding from them since 1988 and extensive funding from NIDA, the VA, and NIMH during that same time period. He's led many federally funded studies, including international and US training grants focused on substance misuse and abuse. Dr. Blow has a long history of funding related to research and program evaluation and implementation of evidence-based treatments for substance use and mental health disorders. His areas of research expertise include alcohol brief interventions in healthcare settings, substance abuse prevention, substance abuse screening and diagnosis for older adults, serious mental illness and concurrent substance abuse, suicide prevention, mental health services research, and implementation of evidence-based substance abuse and mental health practices. And so with that, I will turn it over to Dr. Blow.
Thank you so much, Arielle. I really appreciate being here today. And in the short time we have, we're going to try and cover some key points that I'd like to make related to the role of family caregivers with substance use disorders in older adults. Next slide. So my disclosures include my grant funding. In addition, I am the Huss Family Hazel and Betty Ford Foundation National Research Chair on Older Adult Research. I have been the National Research Chair since 2001. I've had the great fortune to work with Hazel and Betty Ford during that time, one of the oldest treatment programs in the United States with facilities around the country, residential facilities mainly. I'm also the scientific co-director of the SAMHSA E4 Center at Rush University, which is a parallel center to the center that is sponsoring this webinar at Harvard. So I'm really fortunate to be able to have roles in both of those areas, and I receive compensation for that. Otherwise, I have no other disclosures. Next slide. So I'm going to give you a quick overview. What are the things that caregivers can, how can you help identify and address problems related to substance use? What's their role in treatment and recovery? How do you support caregiver health and well-being? And then I'll give you some helpful resources, including the website for the E4 Center at the end of the presentation. Next slide. So we know that COVID's had a really major impact, as Dr. Hollerman has suggested, around addiction and substance use in general. The stress and physical isolation of COVID has really led to life changes and worsening for many people, their substance use and misuse. And we know that chronic problems related to alcohol and drug use can weaken the immune system and also put stress on the body's cardiovascular and respiratory systems. It really puts people at much higher risk for a lot of things. And it's really worrying as COVID continues, the impact on older adults. We conducted a national survey, the National Survey on Older Adults and Health, that's conducted monthly at the University of Michigan in collaboration with the AARP. And what we found, this was done in the field last November, so about 9 months or 10 months into the epidemic. And what we found in that national representative sample is that for those that are reporting more isolation at that point, really showing more social concerns, their drinking went way up. So you have the double trouble of increasing isolation and feelings of loneliness and increasing their use of alcohol. Really problematic. Next slide. We know that most of the deaths have come from older people. So, it's really, again, that idea of grief and stress, anxiety, physical isolation has increased substance use, especially alcohol use, and there are new and worsening addiction, relapse, and deaths. And just to remember that during COVID, during the lockdown, the businesses that were deemed essential included the alcohol outlets. And in Michigan, as a legal cannabis state, the marijuana or cannabis outlets were deemed as essential businesses and were kept open. And so there was increases in rates of getting alcohol and cannabis delivered to your door. It's just as easy to get pizza as it is to get cannabis. So you can really very quickly in the legal states, now some 18 states, including the District of Columbia, are legal recreationally, and 38 states are legal for medical marijuana or recreationally. So it's a large portion of people. And I would argue and suggest to you that while number one in our concerns around substance use in older adults is alcohol, number two is rapidly occurring with cannabis in terms of rates of problems. Next slide. So, I've already said this, but I also like the last box on this slide, which is suicide. I don't like it, but I want to point out that the connection of and the intersections between addiction, substance misuse, suicide, and depression cannot be underestimated. People often think, oh, suicide, depression, anxiety. Actually, alcohol plays a major role in suicide. So you really need to be very serious about identifying people with alcohol and other substance use problems because of the heightened risk for all the health concerns, but also because of suicide. Next slide. So a little bit about, how can you help? What are the issues related to identification and, sort of addressing the problem? Next slide. So the first is you got to learn the warning signs, and Dr. Hollerman sort of suggested some of those things. What I would say is that it's very hard to pick out the problem users from the entire population. The best way to identify people who have substance use issues is to screen, universal screening. And how do you screen? You use simple, short screening measures, including the one item NIAAA one item screen for alcohol, which is over the last month, have you had any days that you've had 4 or more drinks on a drinking day? Simple screen. You get a positive for that. Then you can follow up with other really great validated screening instruments. Someone put in the chat, the short mass G. This is an instrument that I developed many years ago. It's the Michigan Alcoholism Screening Test geriatric version. It is a specific older adult screening measure, and it is focused on consequences. But you've got to start somewhere, and I would say you should start with quantity and frequency. You've got to get an understanding of, are people using, and how much they're using. So the 1-item instrument is a good one. Then you could go to the 3-item audit C, which is the consumption items from the alcohol use disorders identification test, well validated with older adults, and is only 3 items long, very easy to administer. And then if you need more information, you might get to a consequences instrument like the MASS-G. There are many, many other resources out there in terms of screening. I'll point to the evidence-based practices guide that SAMHSA produced that I chaired the consensus panel at the end of my talk today to give you something that you can go into that. And there are many, many instruments in the appendices that you can use. You need to know what people are taking in terms of the medications. About 150 of the most commonly prescribed medications interact with alcohol, for example. So it's really important that we have a better understanding of those interactions. There's some suggestion that many of the adverse consequences related to alcohol are medication interactions in older adults. So really understanding what those interactions are and being really vigilant about that. You know, recently we've published a number of articles related to benzodiazepines and the risk of benzodiazepines in older adults, the continued use of benzos, that is the sleep and anxiety agents. And you know, this is not a trivial problem. It's a growing problem. It's something that we should be paying attention to. And so that's another big area that we should be focused on. Then you have to add in cannabis, because people are using cannabis to manage their sleep, to manage their anxiety. And for many people with dementia, their caregivers are using cannabis products to manage their behavioral symptoms of dementia. And several states actually have approved it for medical use, even though there's no evidence whatsoever about its effectiveness. But if you go on the internet, you'll see lots of anecdotal reports that this is life-saving for people. The cannabis story is one that's evolving. I did a whole webinar on cannabis. If you're interested, I'll give you the link at the end, really getting into the details. Really the switch from smoked product to edibles as being the most dramatic thing that's happening. It's the Wild West out there. But knowing the person that you're caring for, medications, alcohol use, and cannabis use will really go a long ways to help address these issues for caregivers. Develop a plan for getting help. Learn how to connect with the family member to help people really get the kind of help they need. We'll talk a little bit more about that at the end. And then the other thing is when and how to discuss. And what I find is that frank discussions, open discussions that are compassionate, that are partnering, that talk about health risks and health concerns are the best strategies for dealing with these issues with older individuals. Next slide. So what about treatment and recovery support? Next slide. So this is I think a surprise for many people, and that is that most older adults don't self-refer or seek treatment. The percentage of people in public programs in the country that is substance use disorder programs that are over age 60 is only 1.5% every year. It's appalling. We have very few people that are actually seeking care. And it's because people don't self-refer, and actually providers also fall down and don't refer people that need treatment. So really helping people get to treatment, helping them really connect, and having warm handoffs around treatment can be really life-saving for individuals. Just education and brief interventions, motivational interventions that are targeted to specific behaviors are often enough just to help the person either prevent escalation of use, reduce use, or stop their drug and alcohol misuse. And there's a model of care called SBIRT. If you haven't heard of it, it's well covered in many different places, including the consensus panel guide I'll give you. It's screening, brief intervention, and referral to treatment, SBIRT. And the screening piece is something that's central to all of this. You need to identify people. We recommend universal screening for everyone on an annual basis as part of regular physical exam. And at any time when there's major changes like retirement, change of housing, change of health, bereavement, all of those times are trigger points for people to develop continuing problems. So screen universally and target screening where individuals may be at higher risk. Then the brief intervention is a focused intervention that motivates people to have behavioral activation to change. And that can be delivered to a caregiver that might then extend to a loved one, or actually to the loved one, depending on their cognition and other circumstances. Very powerful interventions, proven to be effective. And for those that don't respond to brief interventions, making sure that you actually follow through with referral to treatment and helping people make the transition from having a problem and not addressing it to actually getting care for their problem. Most older adults don't need care from specialized programs. I would argue that, in fact, we can make a lot of gains by doing other kinds of things with older individuals. Next slide. So what are some of the barriers? There's the obvious barrier of resistance to asking for help. People want to be independent and act independent. And they really feel like if they ask for help, they are somehow showing their weakness. Older people really hate labels. You probably already know this already around being called old or senior, but there's also a lot of stigma that continues with terms like addiction or addict. And so people don't want to be labeled. That's one of the biggest worries that our heaviest drinkers have, our heaviest users have, about being identified as someone who is somehow morally deficient because they have an addiction rather than having an illness. Lack of transportation really cannot be underestimated, that this is a real barrier for people just to be able to get the care they need. So really solving that problem, it can be a really big thing. For older people, there's not a lot of significant others to assist in motivation to seek help. Younger people get to care, many get to care because their spouses have had enough and they get forced to do that, or their employer identifies them and they get forced to do that. Older adults have less of that. In fact, one of the main reasons that one of the main strategies for people to get into treatment as they get older is from criminal justice involvement, drinking, driving, arrests, and other things related to infractions. That's really sad because providers are less likely to refer these individuals and they're getting into care in other ways. We also have a lot of gaps. We have gaps in our substance abuse service delivery network. We have major gaps in our aging services network and our mental health services, and they don't talk to one another. The older person needs people to talk to one another, and caregivers can help be the glue between these systems. Next slide. So, what are some obvious things? What can caregivers do? Well, avoid use of substances in front of a loved one. Seems like a straightforward thing, but it's amazing to me how people have drinking partners, even as you have someone that's doing caregiving, and that continues into that relationship. Try to offer non-alcoholic beverages during activities, go with their loved ones to appointments and offer to help with support during those appointments, accompany them and drive them to care, as I suggested earlier, and then be available to talk to them if they start having the urge to drink or use substances. That social support can really be amazing and really very valuable for older individuals. Next slide. What can providers do? Well, involving caregivers in the discussion around the older adults treatment, obviously with consent, but really caregivers can play a major role in helping older individuals, first identifying them through screening, but then helping them with motivating them to maybe change their behavior, identifying what their goals are and what their values are, to make sure that they are understand that the role of their use of substances may be problematic for them to have the goal of living in their home or living independently or seeing their grandkids or whatever. Really working with individuals to try to identify what the goals are, and then to leverage that to help with identifying what are the triggers that people might be able to use to help them change their behavior. Emphasize ways to provide support. How can they help with making sure that the person is safe and well? And one of the most the best identifiers for people with substance use disorders, and caregivers are in a good position to see this, is alcohol bottles around the house. It's an obvious thing, but if you're seeing alcohol, if it's hidden alcohol bottles throughout the house, you got a real problem with drinking. And so making sure that you're not supplying, you work with individuals to not supply the substances, not supply the alcohol and other drugs. Visit the older person while they're not misusing substances, rather than only when there are times of crisis, which can happen. One of my staff members has a family member that they have to visit literally every other day, or things really go to hell. And if they just focused on when he was having a crisis, they would not really be able to manage the drinking. And then finally, if the caregivers and other family members are really having problems, and people have had long careers of problem drinking as they get into older adulthood, and some of them 40 years, 50 years, many who are in recovery for many of those years, but the relationship still can be suffering. And so I strongly recommend Al-Anon as a way to provide support of other people in the community. There are Al-Anon meetings around most communities in the United States, and can be very powerful in understanding the role that they play in supporting recovery. Next slide. So the holiday triggers, this is a really big topic, but really this is a time that we should be paying special attention to, especially drinking, and especially for those that are in recovery, those that are still doing well, but maybe need a little bit of extra support during this time. You increase grief and loneliness, you increase potential drinking alone, and ultimately you can have a lot more problems. So really working on that during this holiday season. Next slide. How do you help them during the holidays? Well, ask how they can make their holiday better. What do they need? Never encourage the use of alcohol, even on the holidays. This is a really critical thing. Alcohol is not the answer. Manage false expectations. Don't expect them to prevent that they feel happy, but pay attention to the signs and symptoms of any withdrawal or depression or anxiety. Encourage them to participate in these mutual help groups that they also attend. And then ask if they are comfortable in taking part in celebrations this year. And it's okay if not. And this has been a tough year, second tough year. Next slide. So just making sure you're having frequent communications. There's been great strides in telehealth and lots of great examples of how technology has really helped connect older adults, especially those that are at risk for misusing substances, obviously needing to help practice and really engaging people and knowing the special things that people need during this time. Next slide. Last bit I want to talk about is caregiver and health and well-being, because the caregivers also need to be helped in all of this. Next slide. So encourage caregivers to ask for help. I like to tell people alcohol is not the answer. And so using alcohol to cope as a caregiver with their caregiving responsibilities is not going to necessarily be a very positive thing. Same to, I would say, about cannabis. Really making sure that they are connected to others, family, friends, and other community members can make a big difference, and helping them ask for help. Taking breaks from the caregiver role and practicing self-care. This is a critical issue. It's something that we often forget as caregivers. And then encourage them to join these mutual aid groups. I really am a strong supporter of it. And there's a number of caregiver support groups out there. AARP and the Alzheimer's Association and many others have caregiver support groups that are very, very productive and can help with the coping that is so necessary to support our caregivers. Next slide. Really emphasizing self-help activities. I've already talked about it. Reducing their use of alcohol and avoiding it entirely if they feel comfortable about that, and then reminding them that their relationships with their loved ones has meaning and still can give them satisfaction, and that substance use may be part of the picture, but you can actually move beyond that. Next slide. Skip this one, please, because I'm running out of time, a little bit of resources, and we'll wrap up. Next slide. So the first resource I want to really point to is this treatment improvement protocol number 26. It was originally, it's a treatment consensus document that was originally published in 1998. I chaired the national panel back in 1998. It was completely revisited and rewritten in 2020, a new version entirely. I chaired this panel also, national experts, and it's really has it looks from many perspectives, providers, stakeholders, individuals, and families. So really it's to help identify, manage, and prevent substance use in older individuals. There's many great screening tools and assessments in it, and the treatments are tailored for older individuals. It's our best estimates of what works and what is really important for older individuals. Next slide. It's available for free. I should have said at the very bottom, SAMHSA.gov. You go into SAMHSA.gov and you can just search for older adult or aging, and this will come up. You can download it for free. These are the chapters. The ones in red really are for caregivers and for individuals who are affected. But there's lots of other good material in here for providers. I recommend it highly. I've talked a lot about this in webinars. You'll be able to, in one of the next slides, I'll show you where you can watch those if you're interested. This is really, there's lots of great materials, 1,500 references, many appendices. You can get most of the screening instruments that you would ever want to use across this. I would highlight the special issue related to substance misuse and cognitive impairment, number 6. This is something that's really unique to this guide, and I think really we were hoping to make it very helpful to individuals. You can download the whole thing or chapters or just look at it online. Next slide. There's also some caregiver support programs that I would point to. The top one is a VA caregiver support. So if you have veterans that are especially connected to the VA system, this is an excellent program. It's a 6-week online workshop on caregiving. The Family Caregiver Alliance is another one. Both of these have content that is related to substance use in it also. Next slide. This is a family therapy guide. This is available also at SAMHSA.gov. Really talks about family therapy and in the context of substance use and mental illness. Next slide. This is the E4 Center. This is the Center of Excellence for Behavioral Health Disparities in Aging. This is a sister center from the center that's sponsoring this webinar. It's to educate and engage, educate, and empower for equity. It's at Rush University. You can easily access materials on e4center.org. Next slide. And its mission is to engage and empower and educate healthcare providers and community-based organizations for equity and behavioral health, focused on older adults and their families. And we do that through a lot of different provisions of education and implementation resources, technical assistance, variety of things. There's a lot of great materials on this for mental health and for substance use. So behavioral health, very writ large. Again, the e4center.org is the way you can get access to it. Many of our webinars are archived there. And if you want to learn more about substance use in older adults, I've given several presentations this year, one focused on cannabis, another on specialized treatment, another general one, another one on benzodiazepines. There's many, many materials out there, so I recommend them highly. And the next slide should be the final one. And thank you very much. I hope this is helpful, a little more fleshing out some of what Dr. Hollerman talked about, and open it up to some questions.
Fantastic. Thank you so much, Dr. Blow. I certainly hope that there might be some questions from those who are in the virtual room. If not, sometimes that means that questions were answered throughout the presentation. We'll give it a minute for folks to either utilize the Q&A feature or the chat box. We may also have, just a couple minutes to go back to the caregiver self-assessment if we want to do that. Dr. Blow, we can see if there are other questions that come in. Something that Dr. Hollerman had mentioned in the beginning about her own experience with her mother did make me think about, I think, some of the resources that you talked about, Dr. Blow, for caregivers. I'm sure that there would be some support in this area, but just thinking a little bit more about maybe some of the discomfort that family caregivers could be feeling in even initiating the conversation. So they might understand mentally what their role could be, or that they could be really instrumental in those conversations. But the discomfort when there is that family relationship or very close relationship, the dynamic they've had for how many years, that could make it feel a little bit more daunting to actually go through those conversations. So I guess I'm curious if either of you have any more insights as thinking about folks in the virtual room or watching the recording or working with patients and might come across, caregivers, how would you encourage them to kind of navigate that discomfort in those initial conversations?
Right. I would say that it's not just families, but also providers have discomfort with talking about what they think of as a very private, I put that in air quotes, topic. And in fact, what I encourage people to do is to be honest about it, to be direct about it, to connect it to what their values are, what their interests are, to try to make it a connection to their health and well-being. To not give up with just one conversation, but to have multiple conversations. This is a process. This is a dialogue. To do it with a non-confrontational sort of attitude, but more of a conversational discussion. To do it where people are that there's real clear motivation that this is because of love and not because of all of the family dynamics that went on before that. Really trying to do that, it's not easy, but I also feel like there's some real opportunities that families have to partner with providers to do some of this also. And so, this is often requires multiple conversations, that you don't give up, you keep going. I like to, the last thing I'll say, and then I'll give Dr. Hollerman a chance. I like to think about the cases that I've heard over many, many years of individuals who have been through hell with substance abuse, with substance use disorders, even really severe problems, multiple episodes of care. And I think about the patients, the individuals, clients that I know about, who talk about how the one conversation that they had made all the difference in the world. And that the idea of trying to instill hope and positivity about the future can make all the difference for someone who's had a pretty crappy existence in many different ways, or may not have really good understanding of the role that their substance use has really played throughout their life, or at least in later adulthood. And instilling that hope and positivity can make all the difference in the world.
Wonderful. Dr. Hollerman, any closing thoughts in that vein, or in any other sense from this presentation?
Sure. I mean, one thing that I've always spoken with family members and patients about is, saying we want to keep you safe, independent, and in the life that you want to live. And here's one of the things that I'm concerned about. I would like to, and go from there. If you always bring it back to dignity preserved, safety and independence in the way that you want to live your life, and integrate discussions about alcohol use from that perspective, then you're likely to get further. What I do think is that patients may not always be willing to reveal the amount that they're drinking. And caregivers may be part of that in the ways that Dr. Blow is also speaking about. So we just have to sort of have our antennas up and sort of ask very sensitive questions about what's happening over time. And I really do agree with Dr. Blow in terms of it takes a village in some ways to deal with this. So a team approach really is necessary in sort of identifying the problem, and then bringing people into treatment. And one last thought is just that to remember, if patients have serious or chronic illness, that they're homebound, that getting them into formal treatments actually might be quite challenging for them. And it's just important to look at the interventions. If you have interventions that can really happen where the patient is in their home, to try to develop those kinds of things. And it could be these very simple things that we're saying, like just having the conversation can make a huge impact.
Wonderful. Well, thank you so much again to our fantastic presenters, Dr. Hollerman and Dr. Blow. If you have questions that come up after this session has wrapped or as you're watching the recording, feel free to be in touch with us. Like I mentioned, we will be sending a follow-up email with materials, and there will be a very quick evaluation that pops up when you close out of this Zoom. We're so appreciative of those who were able to make it live today. And we hope that we'll see you back soon for another training or technical assistance activity. Have a wonderful rest of your day. Take care.